Okay, everybody, welcome back. So I hope you got a good break and you could assimilate what we have understood so far. What I will do is I will quickly show you what we have learned in the class in forms of in small lines that we have learned. I'll just repeat a little bit with you. So far, what I have shown you is okay. So far, what I have shown you is I have shown you only brain CT anatomy. Okay, this is what I've shown you, along with wherever we could make integrated MCQs based on this, we studied that part. Okay, but the key is, so far my goal always has been about to show you normal structures, because what I have seen is many children, they have no idea about the anatomy and they keep struggling. Now see, so now some of you were asking me in the break, sir, if putamen is the place where you have the hypertensive bleed most commonly, what are the other sites where you can have hypertensive bleed? Thalamus, pons, cerebellum. Okay, so these are the places where typically you see. These are the places where typically you will see hypertensive bleed. बेटा hypertension के कारण bleed कब होगा, कहाँ होगा? Putamen में, thalamus में, pons में, cerebellum में. And this is what I said, that if you have a lobar hematoma in an old man, please think of alternate cause. The hypertension is the most important cause of parenchymal bleed in the brain. But here we will think of amyloid angiopathy. अमाइलॉइड बीटा के जमा होने से ब्लड वेसल्स को खराब होना, एंजियोपैथी. एंजियोपैथी मींस डिजीज ऑफ द ब्रेन. नाउ सेकंड थिंग, okay, we also need to know, now whatever images I am showing you in the class are given to you in the print format in the workbook, and also the digital part of that is given in the app already as in the classroom files. So all the images are there, so don't worry about it, but please see. Now, if I say a young patient has a lobar hematoma, in an old person, if you have a lobar hematoma, you think of amyloid angiopathy. But if you see a lobar hematoma in a young man, think of AV malformation. If you have, okay, I'm repeating the hypertensive bleed. बेटा देखो, मैंने बोला hypertension के कारण bleed होगा. So these are the characteristic sites to consider in hypertensive bleed. All in the center part of the brain: thalamus, pons, putamen, and cerebellum. Okay, everybody clear? But if you see lobar hematoma in an old man, think of amyloid angiopathy. In a young person, if you see lobar hematoma, please consider the possibility of arteriovenous malformation. Yes, this is the first slide after the break. Very good. Now, some of you must be wondering, what is AVM? Now, suppose in a normal person, artery should divide into arterioles. The arterioles join into the capillaries. The capillaries join to form the venules. Venules join to form the veins. This should be the normal anatomy. If the artery is directly connected to the vein with a abnormal bunch of vessels called as nidus, we call it AVM. We call it arteriovenous malformation. Okay, are you clear with this? Are you clear? Okay, now let's see an answer. आर्टीरियोवीनस malformation मतलब आर्टरी और वेन के बनने में खराबी. So we don't have a capillary network. You have an abnormal bunch of vessels called as nidus connecting the artery to the vein. Now the high pressure blood from a artery is not getting dissipated because there is no capillary in between, and it is going into the vein. And that is why the veins rupture And if you have a AV malformation in your brain, it can lead to brain hemorrhage. So if you see a atypical site hematoma in a young man in brain, like you see a lobar hematoma in a young man in brain, you think of alternate cause like AV malformation. Everybody understands this? So do you understand what is this? So this is how we think. The reason is, this is the first slide after the break, children. Oh, the entire idea that I want you to make sure is, I do not want you to memorize. I want you to learn how to think like a doctor when you see a radiological image. Okay, so we will always try to think like a doctor. Okay, if we see a putaminal bleed, all those things of Charcot artery and hypertensive bleed should come back to my mind. Everybody understands? So we need to learn how to think, not what to think. The key in my belief as a teacher is, my goal is not to tell you what to think. My goal is to tell you how to think. कैसे सोचना है, ये हमें सीखना है बेटा. Everybody understands? Okay. Now, once you are able to understand the concept, what I will do is, I will straight away go to a clinical image and I'll show you a clinical image to diagnose. Okay. Let's start looking at the next CT scan. Okay. Okay. Let's start looking at the next CT scan. You can see with me, you can see the brain parenchyma. Okay, bachcho, you can see the brain parenchyma. You can see the skull bone. And can you see something between the brain and the bone? You can see a hemorrhage. Okay. In the next image, you can see a hemorrhage between the brain and the bone. Okay. But between the brain and the bone, beta, you had dura. Between the brain and the bone, actually, you had dura. So you can see a hemorrhage in relationship to dura. But is it outside the dura or below the dura? Beta, tell me, is it extradural, that means outside the dura, or below the dura, we will say subdural? Okay, so everybody understands. Okay, everybody understands this. Please see, if this is your skull bone, everybody try to understand, otherwise, it will become difficult. Because, beta, kitna yaad karenge na? How much will you mug up? So let's try to understand. This is skull bone. If this is your skull bone, everybody look at it. Don't type the answer. Just look at the screen, beta. Just look at the screen. Don't type the answer. If this is your skull bone, the skull bone on the outside is covered by periosteum. On the inner side, it is covered by endosteum. Okay. On the inner side, it is covered by endosteum. And outside, it is covered by periosteum. Okay. The endosteum and periosteum, they become continuous at the level of sutures. Endosteum and periosteum, they join together at the level of sutures. Okay. Now, try and imagine an answer, bache. So, do you know there is a fibrous covering to your brain called as dura? Now, dura has two layers. Dura has a meningeal layer, and the outer layer of dura is formed by the endosteum. So remember, dura has two layers. It has an inner meningeal layer, outer endosteal layer. Okay, everybody understands? Dura has two layers. It has an inner endosteal layer, outer meningeal. You can see this is the purple color is the meningeal layer, green is the, and this is where you have your brain. Okay, let me draw it. This is where you have the brain. Okay. Now everybody try to understand and focus. बेटा देखो, मैं चाहूँ तो direct answer बताऊंगा, but मैं चाहता हूँ आपको कारण बताऊं. That will you require a little patience, but you will never forget what I'm telling you, बेटा. Please see. Between the skull bone and the endosteal layer of dura, you have an artery called as middle meningeal artery. Okay. Between the skull bone and the endosteal layer of dura, you have the middle meningeal artery. If suppose you get hit by a car or you have an accident and the skull fractures, and not only does the skull fractures, the middle meningeal artery ruptures. If the middle meningeal artery ruptures, the blood will start accumulating in this space. This is your extradural space. So this is your extradural space, or we will say extradural hematoma. And that is what you have read in forensic medicine, pathology, surgery for EDH. Now, question is, can this EDH cross the suture? No, it will be limited by the sutures. It will not cross the suture lines. Everybody clear or not? Extradural hematoma will not cross the suture lines. Why it is not crossing the suture line? Because the endosteum is fusing with the periosteum at the level of the sutures. Now this hemorrhage, because it cannot cross the suture lines, it starts accumulating in this direction. Okay, and so this is where your dura is. Everybody look at it now. Are you able to see now? It is going to push the dura. So we call it extradural. It is outside the dura, but limited by skull sutures. Now, please look at it and answer. Everybody now look at it. I want you to understand and answer, बच्चे है ना? ये bone देखेंगे, है ना? यहाँ पे होता है, we have our coronal suture. If you remember from anatomy, this is where you have the coronal suture, and this is where you have the lumboid suture. Okay, can you see? I'm repeating now, bache. Can you see this hematoma that you see here, more white than the brain, hyper dense? It is going till here, but it is not crossing the coronal suture. It is not crossing the lumboid suture. So it appears that it is limited by the sutures. Because it cannot cross the sutures, it is expanding in this direction, and that is what is making it as a shape like this. Can you guess the name of the shape? We will say biconvex, or you will say lenticular. Are you clear? Are you clear or not? Are you able to understand? I have given you a reason. I could directly say, बच्चे याद कर, EDH is biconvex. आप हाथ रखते याद करते रहते. You never understand what is going on in medicine. The key here is that EDH is located outside it is located between the inner table of the skull bone and endosteal layer of dura. And that is why it cannot cross the suture lines and becomes biconvex in shape. Are you clear? Everybody understands? Will you be able to answer this? EDH, extradural hematoma, is limited by skull sutures. True. Biconvex in shape. True. I want you to answer. I am saying EDH can cross the midline. Yes or no? Okay. You need to tell me extradural hematoma, okay, can cross the midline. Yes or no? EDH is a very important question, very often asked. EDH can cross the midline. Yes or no? Yes or no? What do you think? The answer is yes. Surprise, surprise. And that is why now you know where you were doing it wrong. But yes, it can cross the midline. Where? Now remember now, suppose you have a EDH in your frontal region. This is where you have the coronal suture. This is where you have the coronal suture. You don't have any suture in the adult in the middle. Remember, in the middle, you don't have any suture. In the embryological fetal life, you have a metopic suture here, but in adult, you don't have it. So this is where the hematoma, if it is there, it can cross the midline. It will be like this. So in the frontal area, if you have a EDH, it will be crossing the midline because you don't have a midline suture there. Are you clear? Are you able to understand the concept now? And do you now see why you were getting it wrong? Because understanding takes a little time to develop. थोड़ा बात करेंगे तभी understanding बनेगा. But if you get impatient and you say, sir, 4 line लिखवाओ हम याद करेंगे, then it would be no fun. Okay, so the key is not in mugging up. The key is in understanding. बच्चे देखो, EDH is limited by sutures, biconvex in shape, can cross the midline, and it is due to rupture of middle meningeal artery. It is due to rupture of middle meningeal artery. Everybody understands? Are you clear with this? Yes, very good. And we need to know EDH. Beta, this image is asked every year in one of the exams. Aana hi aana, beta. EDH to aega aega, beta. You cannot do it wrong. It is definitely going to be asked, beta. It's a surgical emergency. It's a surgical emergency, beta. Hmm? Okay. So I've just added my phone internet. I think because of the storm, I think today the internet at my home is not good. So, but don't worry, we will be able to manage. Okay. Just wait. I think we will be able to get back. We'll be able to get back. Yes. Okay, so we'll be able to get back. Don't worry. So it's a little bit issue with my home's internet today. So it is repeatedly crashing. But don't worry, don't worry. We'll be able to manage it. Don't worry, we'll be able to manage it. We are just trying to get back to this by the time. Okay, okay, okay. So I hope you're all fine there. It's just that today the because of the storm happening. Yes, yeah. Okay. So in between. Okay, so but just let me just share the screen and I will be back. Okay, so let us come back to this. Okay, let's come back to this. It's just बच्चे थोड़ा सा वो आज बाहर बहुत बारिश होने के कारण इंटरनेट जा रहा है बार बार. Don't worry about that. Actually, my challenge here is that in my home it takes a little time for the generator to get back up. So उसमें थोड़ा time लगेगा. Let's see. So this is where we were. This is where we were. We saw the subdural hematoma is concavo-convex in shape, and it is not limited by the skull sutures. It is not limited by the skull sutures because it is below the dura. This subdural is between the dura and the arachnoid, so it is not limited by sutures. It is concavo-convex in shape, and remember, it cannot cross the midline because it is limited by dural folds like falx cerebri. So subdural hematoma cannot cross the midline because on the midline, okay, I will repeat this image. Okay, I'll repeat this image. Don't worry. So now see this image here. Beta dekho, dobara se dekho. You can see a similar hematoma, but it appears to be covering the entire half of the brain. It is not limited by skull sutures. जहां suture होने चाहिए उसके beyond जा रहा है. उसके I am repeating the subdural hematoma totally. Okay, they have written nothing else. Okay, beta, no, don't get panic. Okay, don't get panic. Okay, so please see here. Subdural hematoma, remember, okay, is not limited by skull sutures, concavo-convex in shape, but it cannot cross the midline because it is limited by falx cerebri. Okay, I'm repeating the subdural hematoma again. Everybody okay? Everybody? Okay. Yes, see. Now please try and compare the two. Can you see now in front of you, I'm showing you two images. One is extradural, which is localized. It is not crossing the suture line. One is subdural, which is more spread out because it is not limited by skull suture. So it remains concavo-convex while EDH is biconvex. Everybody understands the concept? Okay. Now please see. If I make a concept here, suppose this is your dura mater, and suppose this is your brain where you have the arachnoid matter and the leptomeninges. From the brain surface towards the dural surface, you have veins. These are called as bridging veins. Okay, between your arachnoid and the dura, you have bridging veins. Okay, now tell me if you can answer, what happens when you grow old? What happens when you grow old? When you grow old, your brain atrophies. Okay. When you grow old, your brain atrophies. Okay. Subdural hematoma cannot cross the midline because it is limited by a midline fold called as falx cerebri. Okay. Now listen to me. Better listen to me. When you grow old, the brain atrophies. When this brain atrophies, what will happen to the bridging veins? Anybody can think of it. बेटा सोच के बताना है. ये ड्यूरा है, ये ब्रेन है, बीच में bridging veins है. When the brain atrophies, the bridging veins will be stretched. They will be under tension. When they are under tension, they rupture. And that is why subdural hematoma is commonly seen in old people due to rupture of bridging veins. Are you clear? Are you able to understand now? Many of you were asking the etiology of SDH. Subdural is due to rupture of bridging veins. These bridging veins typically are stretched in old people because of their brain getting atrophied, and that is why you have SDH in old people. Everybody clear? Everybody clear? Now, second question. Now, second question answer. Now, suppose you have a case of child abuse, and a parent who is shaking the child violently, shaking an infant violently, we call it shaken baby. Now, try and understand. Everybody, try to understand. If if you violently shake a baby's body, the head control is not there. When the head control is not there, so head will be like this. Okay. So when the head is bobbing like this, so the dura will shear over the arachnoid like this. It will move like this, and the bridging veins will rupture. And that is why a typical brain hemorrhage that you see in shaken baby in child abuse is also subdural hematoma. So two things to remember are, in shaken baby syndrome also you will have subdural hematoma. So you will have a classical question like this. A child has subdural hematoma, what should you suspect? You should always suspect it could be child abuse. So subdural hematoma is seen in shaken baby syndrome, and it is also seen in old people, and both of them it is venous. It is due to rupture of bridging veins, while extradural hematoma was due to middle meningeal artery rupture. Okay, are you clear with this or not? Extradural hematoma due to rupture of middle meningeal artery, subdural hematoma due to rupture of bridging veins. Okay, everybody now look at it. Now in brain, can you see in brain, are you able to see in the brain these dark areas? Can you see? These dark area are your sulci. These are your sulci. And the sulci are dark because they have CSF. The sulcal spaces, they appear dark because they have CSF. My question to you is, why are the sulci in this patient appearing so prominent? The sulci in this patient are appearing prominent because the gyri have shrunken. This must be an old man or probably an alcoholic, like some of you are saying. Possible. In alcohol also, the atrophy of the brain will happen with chronic alcoholics. But are you clear with this or not? In old people, the sulci become prominent. These are your cerebral sulci, which are dark because of atrophy, because of these gyri getting thinned out. That is the idea here. Are you clear? Very good. I can see most of you are able to answer. So if you are able to answer, try telling me the problem in the next picture. Now you can see, before the break, I was only telling you anatomy. Now I'm showing you diseases. My goal here is to make sure that you understand the anatomy and the disease both. Okay. Now look at the image and tell me, where is the problem in this image? What is the disease? Now see, children, this is your lateral ventricle. This is your third ventricle. Do you think this white thing that you see here is the disease? Shaken baby leads to subdural hematoma. Some of you were asking. Now, are you clear with this or not? Can you see this white thing posterior to the third ventricle? What is that? Okay. Anybody? Okay, now see. So the white thing that you see behind the, if you remember the anatomy that I taught you, on either side of the third ventricle you have the thalamus. On either side of the third ventricle you have thalamus. Posterior to third ventricle you have the epithalamus. This epithalamus forms a structure which is known as pineal. And pineal is known to show physiological calcification. This is not the disease. This is normally calcified pineal gland. So I am sure you can now pick up. This is not a disease. This is normally calcified pineal gland that you see here. This is not the disease. Okay. Now let's see if you can answer. Do you think the disease is the structure that I am now marking? Can you see in the lateral ventricles, beta, can you see in the lateral ventricles, there is some white area in the lateral ventricle. What is that? That is nothing but physiological calcification in your choroid plexus. Do you remember in the choroid plexus, you have the function is CSF production. With age, even the choroid plexus also calcified. Everybody clear? Everybody clear? So this is not the disease. This is pineal and this is choroid plexus. Everybody clear? Everybody able to understand this? Choroid plexus बच्चे जो ventricle में CSF बनाता है ना बेटा वो वाला. Okay, very good, brilliant. Now, but these are not the disease. This is physiological. Where is the disease located? Disease कहाँ पे? Okay. Disease कहाँ पे? है ना? Disease कहाँ पे? Now, if I look at this area, this is where you should be seeing your sulci. Do you agree the sulcal spaces in this patient are more white? I will say sulcal spaces are appearing hyperdense. This was the image that you had last year in the NEET PG exam. The sulcal spaces are appearing hyperdense. बच्चे सोचें sulci hyperdense क्यों होंगे? यहाँ तो CSF होना चाहिए था. CSF should be dark, but this is white because you have blood. So if you have blood in the sulcal spaces, that means you have blood in the subarachnoid space. And this is what is called as subarachnoid hemorrhage. Are you clear with this or not, बच्चे? समझ आया कि how to differentiate between different kind of hemorrhages? Okay. So are you clear with this or not? Now we can see there is blood in the sulci, and that is called as subarachnoid hemorrhage. In short form, we will write it as SAH. What will be the presentation of the patient? The patient will be written in the MCQ as patient comes to you with worst headache of his life. Patient comes to you with worst headache of his life, which is popularly called as thunderclap headache. But the question is, why would you have it? What is the cause? So, clearly, if we can exclude trauma, if the history is not telling me about trauma, okay, are you clear with this? If the history is not telling me about trauma, excluding trauma, the most common cause of subarachnoid hemorrhage other than trauma is a ruptured berry aneurysm. Okay. So can you imagine all of you? Did you remember we saw the brain blood vessels and I described them that they are in the interpedunculair fossa, in the cisterns. If at branch point in any brain vessel, if you have a congenital weakness and you have an aneurysm, if that aneurysm ruptures, it will lead to blood in the CSF. In the subarachnoid space, you will have blood. That is called as SAH. That is called as subarachnoid hemorrhage. Are you clear? So this is the image that they showed last year in NEET exam. They said a 45-year-old lady has severe headache. Look at the CT and tell us what has happened. You just had to mark SAH. Okay. So this is how subarachnoid hemorrhage looks like. Sulci appear hyperdense. the CSF is replaced by blood. Are you clear? Okay. Now I want you to look at this image and answer. Even this image is a CT scan. You can see the bones are appearing white. We are looking at a CT scan. But look at the image that I'm showing you. Look at the image that I'm showing you. My question is, are we able to see the brain parenchyma in this image or the blood vessels? Anybody? We are able to see the blood vessels. The blood vessels are seen more prominently than the brain parenchyma. Are you clear? Yes. So that means this is a CT scan done to look at the blood vessels. We will call it CT angiography. So in short form, you will read this word multiple times. We will call it CT angiography. A CT scan optimized to look at the blood vessel will be called as CT angiography. Gradually, I will tell you exactly how we do it, but let's understand. Is the investigation of choice for a cerebral aneurysm. Are you clear? So if you notice in the image, you will be able to see, can you see this area of focal dilatation? Can you see there is a focal dilatation in the blood vessel at the branch point? This is how an aneurysm would look like. So I'm sure we will remember this, that investigation of choice to look for a cerebral aneurysm is, what will you mark, beta? You will mark CT angiogram. A CT scan which is optimized to look at the blood vessel is called as CT angiography. So I'm sure many of you will be able to pick it up that these two images are connected. One image is showing you SAH, the second image is showing you the cause of it. We are able to see some integration. The first image is showing you the subarachnoid hemorrhage. In the bottom image, you can see the cause of it. Are you clear? Are you able to understand the concept here? Yes, you are. Very good. Now, once you are clear with this, I am going to give you a little bit complicated thing. I will make it little bit tough, but I want you to listen to me and see with me. Okay? Don't get panic, but I want you to understand. What is the gold standard investigation for a cerebral aneurysm? ठीक है? Cerebral aneurysm के लिए gold standard investigation किसको माना जाएगा? What is the most accurate investigation? Okay, that is the question to be answered. So to answer this question, what we will do is, we will go to the folder here. We will open a video. Okay. So what I want you to see with me here is, I want all of you to see with me. Are you able to see this? Okay. I know you were not watching. अच्छा बीच में व्हाट्सएप मत खोलो ना बेटा, जस्ट इधर देखो. ओ इंस्टा पे कोई लाइक आ रहा है, नोटिफिकेशन आ रहा है, नहीं ना, क्लास देखते हैं ना. प्लीज सी दिस. नाउ दिस इज हाउ अ कैथेटर एंजियोग्राम लुक्स लाइक. ओके, सो व्हाट वी हैव डन इज we have taken a catheter. Okay, listen to me, everybody, listen to me, wake up. We have taken a catheter, put that catheter into your femoral artery. From the femoral artery, we have taken the catheter into the aorta, and from the aorta, we have taken it into the internal carotid artery, and we have injected the dye. Okay, so dye catheters may say dye inject, it has gone into the internal carotid artery. So this is your internal carotid artery. In the midline, you can see the ACA. And this branch which is going laterally is the MCA. And anterior cerebral artery midline में होती है और MCA laterally जा रही होती है. Okay, so this is the DSA. This is how the catheter angiogram would look like. My question is, why we are not able to see the bones? सिर्फ blood vessel क्यों दिख रही है, skull की bones क्यों नहीं अच्छे से दिख रही? You understand? We have injected the dye and taken an X-ray to look at the blood vessels. Then why bones are not visible? Because the bones are digitally removed from this image. इसको कहते हैं DSA, digital subtraction angiogram. Okay, now I'm going to remove this image and we are going to come back to this here. So in your exams, they will only write like this. Gold standard for cerebral aneurysm is, the answer is DSA. What is DSA? DSA is digital subtraction angiography. What we have subtracted here? We have subtracted the bones. Digital subtraction angiogram. Okay, are you able to understand this or not? DSA. Okay, इसमें हमने बोन को हटाया और डाई इंजेक्ट करके आर्टरी को देख रहे हैं. डाई कैसे दी? कैथेटर से. कैथेटर कहां किया? आर्टीरियल पंचर करके we have taken the catheter from the femoral artery and we have pushed it into the aorta, from aorta से carotid artery, and we have injected the dye. Everybody understands this? Understood? Okay, अब समझ आया? मतलब समझ आया कि नहीं? My key here is understanding. मेरा ये मानना है, anything that you understand stays with you forever. Anything that you memorize vaporizes like a volatile subject. तो समझते हैं ना बेटा? Let's spend time and understand, है ना? Okay, now anybody wants to, just go to the, the topmost level of understanding. I'll just show you बेटा, है ना? I'll just show you. I just want you to see a picture with me. Okay, are you able to see this? So now what is happening here is, in this DSA, okay, but that video question also is given in your DQB. ये जो video में दिखा रहा हूँ, they're given in your DQB in the video-based questions. Don't worry. Okay, now please see, beta. So while doing DSA, if I take the catheter, okay, if I take the catheter and I take a micro catheter and I make it, I fill up the entire aneurysm, I can actually obliterate the lumen of the aneurysm like this. This procedure that you are seeing in front of you now is called as endovascular coiling. This procedure that you see here is called as endovascular coiling. Can you see here or not? आपने एक तार ली और उस तार को एनोरिज्म के अंदर भर दिया to obliterate the lumen. So this is called as endovascular coiling or coil embolization of the aneurysm. So this is how it looks like. Okay, everybody understands? I'm repeating. DSA का full form is Arpit beta, digital subtraction angiography. Okay, digital subtraction angiogram. Okay, now once you are clear with this, I am coming back to my slides. Now, so what did we learn so far in the class was, I explained to you about CT, normal CT brain, then I explained to you hypertension से जो ब्रेन पैरेंकाइमा में हेमरेज होता है वो कैसा दिखेगा, एंड अदर कॉजेज होंगे जैसे कि अमाइलॉइड एंजियोपैथी, तो क्या होगा. देन आई शोड यू व्हाट इज हाउ टू आइडेंटिफाई EDH, SDH, SAH. Are you able to understand this? And we saw different causes also. If you have bleeding in the brain parenchyma, the cause is different. If you are bleeding in the extradural space, the cause is different. Subdural में अलग है. ऐसे तो सोचेंगे ना. Everybody understands? Okay. Now I can see that most of you are able to follow this. Now once you are able to follow this, okay, once you are able to follow this, I want you to see an image with me. बच्चे आप, मैं चाहता हूँ सभी बच्चे देखें. I want you to follow an image and tell me, okay, this was your ACA territory, this is your PCA territory, PCA territory, okay, ACA territory, okay. Any one of you can look at it and tell me, okay, do you see a dark area here, a dark disease? It is not white, it is dark. So when it is dark, I will say there is a hypodense lesion in the brain. Okay, what is the shape of this disease? This disease is shaped like a wedge. Okay, क्या आप बच्चा पार्टी देख पा रहे हैं? Okay, okay, can you see it here or not? You can see a dark disease, hypodense lesion, which is shaped like a, okay, is shaped like a wedge. Okay, but let me repeat. Some of you were asking, investigation of choice for cerebral aneurysm is CT angiogram. But the most accurate is DSA, and while doing DSA, we can also coil the aneurysm. That is what I told you. Now, this is how an infarct in the brain looks like. And what is the territory involved? We can clearly see this is the MCA territory infarct. Okay, this is an infarct. Now, my question to you is, why, sir, but why it is wedge-shaped, why it is hypotenuse? Please try and understand. Why is the infarct appearing hypodense and why it is like a wedge? Now suppose this is any solid organ, okay, this is any organ, The arterial supply of the organ is like this. The artery enters the central part of the organ, then divides into further branches and supplies the organ. So that means this artery has a vascular territory which is shaped like a wedge, with the apex at the hilum and the base at the base of the organ. So if I now say, I want everybody to hear me out. If I now say, कि बच्चे देखो, the vascular territories in our body are, beta batao, shaped like a wedge. So vascular territory is shaped like a wedge. So infarct also should be shaped like a wedge. Okay? Okay, if it is a large artery which is getting occluded, बच्चे समझ रहे हैं, then you will have a wedge-shaped infarct. But imagine now, if one of these branches gets blocked, one of the smaller vessels get blocked, then what will happen? अगर एक छोटी vessel block होगी, then you will have a small infarct like this. So if you see a small infarct like this, which is less than 1.5 centimeter, we call it a small vessel occlusive lacunar infarct. Are you clear or not? Do you understand? Not every infarct will be this large wedge-shaped infarct. Bhai, agar main vessel band hogi, you can see in my diagram, if the main artery is occluded, it will be a wedge-shaped infarct. But if a small branch is occluded, you will have a small lacunar infarct. Now, you will always see this terminology in your medicine class also. If you see a small, less than 1.5 centimeter infarct, that tells you it's a lacunar infarct, it's a small vessel infarct. Everybody clear? Okay. So that is the reasoning and rationale why it was like a wedge. Now my question is, why it is hypotense? Let's try to understand. Suppose an artery is blocked in the brain, so the blood supply of the brain is compromised. We will call it ischemia. Okay? Why do we need blood supply to the brain? Why do you need blood supply? Because we need oxygen. We need oxygen to burn the glucose, and oxygenated blood is coming from the arteries to the brain. If the artery is blocked, what is blocked? Oxygenation of the brain is blocked. If oxygen is not there, ATP will not be produced. The ATP in that area will be reduced. Do you agree? Yes. If ATP is not there, sodium, potassium, ATPase cannot function. When the sodium potassium pump does not work, the neurons become swollen. So this is what they will tell you in pathology, that in an infarcted area, if you look at the infarcted area under the microscope, the neurons appear swollen. Are you clear with this? Yes? Okay, the neurons will appear swollen. Okay, now please see with me and answer. This is not visible on CT. We cannot see this on CT. What happens is, after the neurons are dead and swollen, later on, even the capillary endothelial cells, they start to die. When the capillary endothelial cells die because of ischemia, the water from the capillary starts to leak. So we will use a term here, capillary are leaking, so vessels are leaking, we will say vasogenic edema. And this vasogenic edema happens after 6 to 24 hours. Okay, I'm repeating everybody, I'm repeating. Okay, I'm repeating, bachon, I'm repeating, please listen to me. So suppose you have ischemia. Ischemia will lead to reduced oxygenation of the brain. Okay, reduced oxygenation of the brain will lead to reduced amount of ATP. If ATP are not there, the sodium potassium ATPase will not function. If sodium potassium ATPase is not functioning, the neuron will be swollen. Then later on, the endothelial cell damage will happen, the capillary will be leaking, and there will be surrounding edema. आसपास सूजन हो जाएगी, edema हो जाएगा, which is called as vasogenic edema. It takes 6 to 24 hours to develop. Okay? Now see an answer. Okay? बच्चे देखिए बताएं मुझे. Now tell me, why is the brain infarct appearing hypodense? ये brain infarct hypodense क्यों लग रहा है? Because you have edema here. यहाँ पे टिश्यू में इडीमा मतलब होता है टिश्यू में फ्लूइड पानी ज्यादा होना. टिश्यू हैज मोर वाटर हियर बिकॉज द कैपिलरीज आर लीकिंग बिकॉज द एंडोथेलियल सेल्स आर डेड एंड दैट इज व्हाई इट इज अपीयरिंग डार्क. Remember, water is more dark than the brain. You remember CT Hounsfield scale I explained. So infarct is hypodense because of that edema that you see here. This is the edema. Okay, are you clear? Everybody understands? Edema means increase in the water content. So can you answer a question now? CT scan in a patient with brain infarct can be normal in first 24 hours. Yes or no? Anybody? CT scan of the brain in a patient with brain infarct, okay, can be normal in the first 24 hours. Yes or no? Yes, it is possible. Why? Bolo beta, why? Because the edema, the vasogenic edema takes time to develop. It can take up to 6 to 24 hours to develop. And that is why you might see when you start your final year postings, right now you're not going to any postings as an intern or any, because everybody is only seeing COVID patients. But later on you will see that it is possible that you might have a patient with hemiplegia, but the CT is normal. Now you know the why behind. Because the vasogenic edema in a patient with infarct takes time to develop. And that is what we can see on a CT. Everybody clear? Okay. Once you are clear, I want you to look at the next CT scan and tell me where is the disease located in this CT scan. Do we have any disease in the CT scan? Okay, I can see most of you are able to answer correctly. Now, some of you have a doubt. Sometimes you will see that I will be answering most of your doubts, but sometimes I may not be answering. So if I'm not answering, that means that doubt is not relevant. Okay, so just understand that that means that you're asking something which is not your reality. Okay, otherwise I will be answering everything, beta. Okay, I'll be answering everything. Okay, everybody now look at it. Now this is your frontal sinus. Okay, don't get confused. This is your frontal sinus. Patient is lying slightly obliquely, so you can see the orbit on the one side. Other side, he's slightly tilted when he's getting a CT done. Okay, I will explain to you, Pooja, but listen to me first. बच्चे please listen to me ना. बेटा type नहीं करेंगे ना, पहले सुनेंगे ना. What is this structure? Can you guess what could be this? Can you see this hyperdense blood vessel here? What blood vessel could this be? This is middle cerebral artery. This is your middle cerebral artery. We saw this middle cerebral artery, remember? Was going from middle to the lateral surface. But why it is dense? Why is the middle cerebral artery on one side appearing hyperdense? Because it has a blood clot inside. So if you see hyperdense MCA, it is telling you that there is a thrombus inside. So usually this is the earliest thing that a CT can ever show. So if they ask you, earliest CT sign of brain infarction is hyperdense blood vessel or hyperdense MCA sign. Now you will appreciate why I was spending all those hours explaining to you the anatomy. नहीं तो अभी आप फिर पूछते सर ये middle cerebral क्यों है, anterior क्यों नहीं है, posterior क्यों? Understand? Because I have to tell you the normal first, otherwise there is no fun in looking at the diseases better. Do you agree? This CT scan of the brain shows hyperdense MCA, which is the earliest CT visible sign of brain infarct. Are you clear with this? Okay. So now again you see, this is what is happening first. First there is a thrombosis of a vessel, then gradually the edema will develop. So the earliest CT visible sign of brain infarct is hyperdense MCA sign. Are you clear with this, bache, or not? Okay. But I can see some of you children are asking, sir, agar CT baad mein bata raha hai, so what should be the IOC? So again, this question I will answer when I will teach you MRI. Are you clear? So for brain hemorrhage, CT is excellent modality, and we saw a lot of detail about in hemorrhages. But when it comes to brain infarct, CT is not so good in the first 24 hours. And this is where I will talk about infarct again when we will talk about MRI. I will talk about infarct again when the MRI will be done. Are you clear? Are you clear? Okay, everybody understands. Now my question to you is, okay, beta ye batana hai, do we have a venous infarct also? क्या ऐसा हो सकता है कि venous infarct हो बेटा? Arterial तो होता है. Can you have a venous infarct in the brain? Anybody? Can you have a venous infarct in the brain? Yes or no? अच्छा बच्चे छोड़ो. Tell me, do you have veins in the brain or not? Veins होती भी है कि नहीं होती? So we have veins in the brain. Let me prove it to you with the anatomy diagram. We have veins in the brain. Okay? Okay? Yes. बिल्कुल ठीक है. I think most of you are able to pick it up. पहले thrombus दिखेगा, बाद में edema दिखेगा. But you may not be able to see thrombus in many patients. तभी CT इतना अच्छा नहीं है. Okay? I will answer all these questions again when I show you MRI. Okay? Don't worry. Now, so we have veins in the brain, and this is veins that you can see. Let us try to label the anatomy. Let us try to label the anatomy. This is your superior sagittal sinus. Superior sagittal sinus. And a large superficial vein drains into the superior sagittal sinus. It is called as vein of Trollard. A large superficial vein drains into the superior sagittal sinus is called as vein of Trollard. Okay? Okay, shabash. Okay, now see. Now this is your transverse sinus. Transverse sinus. The transverse sinus has a superficial vein called as vein of Labbé, which is draining into the transverse sinus. The transverse sinus will further drain into the sigmoid sinus, and the sigmoid sinus will drain into the jugular vein. Okay. The sigmoid sinus is connected to the cavernous sinus via the petrosal sinuses. We can see this here. Are you clear? Okay. Yes. Another thing that I want you to see is I want you to see the deep veins of the brain. Deep veins of the brain. From the thalamus and the striatum, you have the thalamostriate veins, which drain into the internal cerebral veins. Both sides you will have internal cerebral veins, and they will join to form the great vein of Galen. They will join to form the great vein of Galen. The vein of Galen will join the inferior sagittal sinus to form the straight sinus. Are you clear? Are you able to understand this or not? Okay. Oh, that patient was oblique by mistake. There was no science in that patient. Okay. Everybody understands? Okay. Everybody understands. Now, I'm again showing you again. Bache dekho dobara se. Please see with me. Superior sagittal sinus. The vein that is draining into superior sagittal sinus is the vein of Trollard. Vein that is draining into the transverse sinus is vein of Labbé. Transverse sinus continues into the sigmoid sinus. Sigmoid sinus continues into the jugular vein. And sigmoid and the cavernous sinus are connected by the petrosal sinuses. Deep vein are thalamostriate veins. Internal cerebral vein formed by thalamostriate. Both internal cerebral vein will join to form vein of Galen. Vein of Galen, inferior sagittal sinus, and vein of Galen will join to form the straight sinus. Okay. Now let's imagine. Okay. Let's imagine. Okay. We are not in a rush. We need to understand. Okay. समझना है बेटे, समझना है, भागना नहीं है, समझते हैं बेटे, ठीक है. Suppose करते हैं, somebody is clinically having a hypercoagulable state. किसी का coagulation का ताकत बढ़ गया है, क्यों? Probably because of a complication of pregnancy. You might have studied pregnancy में it's a hypercoagulable state, or maybe somebody is dehydrated. So these are usual things that they will write in the question. A pregnant lady, or they will talk about dehydration. These are the people who are, okay, Okay, so I can see some questions on vasogenic edema, cytotoxic edema. I want you to wait. I will explain them when I show you MRI. Don't rush. I will be able to tell you everything, but it will come at the appropriate, time. Okay, okay, bache. Okay, very good, shabash. So hypercoagulable states like pregnancy and dehydration. What can happen in them? In these patients, you can develop a venous thrombosis. We will call it cerebral venous thrombosis. किसी ने सुना पहले? CVT, cerebral venous thrombosis. Okay. Somebody was asking me to repeat the vein of Labbé. That is the vein of Labbé for you. The superficial vein draining into the transverse sinus, vein of Labbé. Okay. Now please see an answer. Okay, beta. Let's try to understand the concept here. Abhi, this is not for radiology. Just I'm giving you the idea behind it. Then I will show you the image to identify beta. Okay. Plus, see with me, beta. If this is your artery, these are your arterioles. This is your capillaries. Okay, bache? These are your venules. These are your vein. Okay, bache? Now, suppose a pregnant lady has a hypercoagulable state and she develops venous thrombosis, cerebral venous thrombosis. Okay. Any one of you can think and answer if you have a thrombus in the vein in your brain, okay, what will happen to the capillaries? Beta, सोच के बताना है. If you have a venous thrombosis, listen to me, beta. Stop typing about the time buying, beta. I have told you multiple times, beta. I don't look at time when I'm teaching, and I want you to, not look at the time and try and understand. Because बच्चे time तो वो मैंने बताया ना, ऑफिस में क्लर्क देखते हैं बेटा. I told you ना, वो 4 बजे कब बजेंगे, घर जाना है, because they don't enjoy it. If you enjoy it, there should be no time issue. Please listen to me, beta. Please listen to me. Okay, if you have a venous thrombosis in your brain, what will happen to the capillary? Tell me. The capillary will start to leak. Capillary will start to leak. When the capillary is leaking, you will have surrounding edema. You will have surrounding edema. Very good. Now you will have edema. Now tell me, bache, tell me, capillary in the brain is giving oxygen to the brain parenchyma. If you have edema around the capillaries, let's see if you can answer. Agar capillary के आसपास edema है, सूजन है, if you have edema vessel around the capillaries, what will not happen? Oxygen transfer will not happen, and that tissue will die. That is called as infarct. This is the pathogenesis of venous infarct. I see many children getting confused. Sir, vein बंद होने से कैसे infarct हो गया? The reason is, if the vein is thrombosed, the capillaries become leaky, and if there is fluid around the capillaries, it does not allow tissue oxygenation, and that tissue dies. Venous infarct. Now, tell me, listen to me, children. Listen to me, all of you. What about arteries? Artery is open. The artery is sending high pressure blood into the infarcted tissue. So do you agree, in a dead tissue, capillaries will be fragile? In a dead tissue, capillaries are fragile and the capillaries rupture. The capillaries rupture. So when the capillaries rupture, you develop hemorrhages. You develop hemorrhages. So venous infarcts typically will have areas of hemorrhages, and that is why in pathology they use the term red infarct. Do you recall this or not? In pathology, they said arterial infarcts are pale, venous infarcts in the brain are red. They are hemorrhagic. The reason it is red is because the capillaries in the dead tissue are fragile and they rupture because the arterial blood is coming in. Because it is only the vein which is thrombosed. So this is the pathophysiology behind a venous infarct. Typically, the question will say, a pregnant lady suddenly has headache and altered sensorium, and in the brain you have a hemorrhagic infarct, you think of venous thrombosis. Now, let's understand it. The typical sinus that gets thrombosed is the superior sagittal sinus. Let's imagine the superior sagittal sinus now. Suppose, everybody listen to me. Suppose I take a section here. बच्चे देखने की कोशिश करेंगे बेटा. if I take a section here, section here, section here, section here, okay? Look at the first section. This is anterior, this is posterior. Now, superior sagittal sinus is longer posteriorly, shorter anteriorly. So what happens is, in the first section, this is the first section, superior sagittal sinus will be seen anterior and posterior, but in the other sections, it will only be seen in the midline posteriorly. Superior sagittal sinus will be seen in the midline posteriorly. बच्चे देखें, okay? Now try and look at the CT scan. Try and look at the CT scan and tell me, okay, बच्चे, tell me where is the problem? The problem in the next CT scan is here. Can you see a triangular structure here which is appearing hyperdense? Can you see this triangular structure is located in the midline posteriorly? So that means it must be the superior sagittal sinus. Now, artery when you cut in cut section is round, but the venous sinuses are like this triangular in shape. So the superior sagittal sinus is appearing hyperdense. We will call it as delta sign on NCCT. And if some of you will recall, same thing ENT people must have told you when you have ear infection. When you have ear infection, do you remember anybody? Infection can cause sinus thrombosis also. You remember CSOM has a complication of venous thrombosis? Yes, very good, brilliant. So they will also use the term delta sign. A thrombosed sinus on a CT will be dense, and because the venous sinuses are triangular in shape, we call it delta sign. Everybody clear? Okay, this is what is called as the delta sign on CT scan. Seen in venous sinus, cerebral venous thrombosis. Everybody clear? Very good, beta. Very good. So now I will make it slightly more complicated. Suppose I do a contrast enhanced CT. Now, so far, whatever I have shown you was non-contrast CT. I am increasing the difficulty level. Please listen to me and follow the thread. Contrast enhanced ka matlab you have given intravenous dye. Okay. And gradually I will explain to you what is the dye that we use. Okay. So if I give intravenous dye, I want you to answer here. Suppose this is your midline. This is where you have the superior sagittal sinus. The question is, if there is a superior sagittal sinus thrombosis and I do a contrast enhanced CT, better tell me, and I do a contrast enhanced CT, will you see the dye in the sinus? बच्चे सोचो और बताओ, अगर साइनस में थ्रोम्बस है तो क्या डाई उसमें जा पाएगी? Will you have given intravenous dye, the dye should go into the blood vessel, but this blood vessel is thrombosed. Will the dye go into it? No, dye will not be able to go into it. And that is where we have a term called as empty delta sign. Okay, so let me explain to you again with a visual. देखो एक बार, suppose this is a contrast enhanced CT. यहाँ हमने intravenous dye दिया हुआ है. Now, how do I know that dye दिया हुआ है? Because I can see the blood vessels taking up the dye. You might appreciate it. It's okay. But please see it here. This is the superior sagittal sinus, midline posterior structure. Now this sinus is appearing dark. अगर मैंने dye दिया हुआ है, if this is contrast enhanced CT, why is the sinus appearing dark? Why it is not taking up the dye? Because it is thrombosed, and that is why people keep getting confused. CCT पे the sign of venous thrombosis is called as empty delta sign. अब समझ आया बेटा? NCCT पे we call it delta sign. CCT पे we call it empty delta sign. Are you clear? Are you able to understand this? Yes, very good. So both of them are signs of cerebral venous thrombosis, but on NCCT, on a non-contrast CT, we will call it delta sign. On a contrast enhanced CT, we will see empty delta sign. What is CECT? CECT stands for कॉन्ट्रास्ट एनहांस्ड सीटी मतलब इंट्रावीनस डाई देने के बाद किया गया सीटी. कॉन्ट्रास्ट एनहांस्ड सीटी इज CCT. एवरीबडी अंडरस्टैंड्स दिस? बच्चे क्लियर? ओके, वेरी गुड. ओके, आई एम रिपीटिंग अगेन. ओके, आई एम रिवाइजिंग फॉर यू अगेन. Slightly complicated, but if you are able to see, you will be able to pick it up. है ना? देखो कोशिश करना. So if I say, if it is written in your question, this is non-contrast CT, so then we see, if this is non-contrast CT, then why is the sinus appearing dense? It must be thrombosed. So we will call it delta sign. Okay. But on a contrast enhanced CT, the veins and the vessels should enhance. They should take up the dye and they should appear white. But if any vein is thrombosed, it will not take up the dye and we will call it as empty delta sign. माने delta है लेकिन वो खाली है, वो white नहीं है, on the dark है. देखो मैं दिखाऊंगा, बच्चे देखो. This is how it looks like. This, it will look like a filling defect. The term is filling defect. So we say empty delta sign. Okay. Now gradually I will show you the normal sinuses also. But don't worry, I will keep showing you multiple times all of this. But just I wanted to show you some very, very important diseases. And then, I want to first finish with the CT scan and the concepts here. So it is used for all cerebral venous thrombosis. I am showing you for superior sagittal sinus, लेकिन ये टर्मिनोलॉजी किसी भी venous thrombosis में यूज कर सकते हैं, जैसे ENT वाले lateral sinus thrombosis में यूज करते हैं. Everybody gets it? Okay. Now let's see if you can answer. Now this is a CT scan of the abdomen, where the outstanding structure that you can see here is, what structure do you think is this? ये क्या चीज है जो एकदम white है? What do you think is this white structure here? That is your aorta. So that means we must have optimized this CT for looking at the blood vessel. What is this? CT angiogram. Okay, this is CT angiogram. Okay, everybody? Okay. Okay, so once you're clear, my question is, CT angiography, the dye is given intravenous or intra-arterial? Beta, you need to tell me. CT angiography, the dye is given intravenous or intra-arterial? That is the question. You need to answer. कैसे दिया हमने? डाई कैसे देते हैं CT एंजियोग्राम में? Is it given intravenous or intra-arterial? And you'll be surprised to know the answer is intravenous. Okay. CT angiography, the dye is given intravenous. Everybody clear? Okay. Now, so you might say, sir, intravenous dye, how it has reached the aorta? Okay. Intravenous dye, when I give IV, it goes from my arm. Okay, it goes from my arm into my brachial vein, into the axillary, into the superior vena cava. Then it goes into the right atrium. From the right atrium, the dye goes into the right ventricle. The right ventricle will pump the dye into the pulmonary arteries. Okay. From the pulmonary arteries, the dye will go into the pulmonary veins. Pulmonary veins will send the dye into the left atrium. From the left atrium, the dye goes into the left ventricle. The left ventricle, when it pumps it, it goes into the systemic arteries like you see here. Okay. So I'm sure now you can follow. Even if you give the dye intravenous, it will go through the heart and then it will reach the aorta. Are you clear? CT angiography is done with intravenous dye. And second thing I want you to know is, if I give intravenous dye, it goes into the RA, then into the RV, then into the pulmonary artery, then into the pulmonary vein, then into the LA, then into the LV. So after IV dye, the dye will first go into the pulmonary artery, and then after a delay, it will come into the aorta. Is everybody clear? Is everybody clear? है ना? Okay, जो dye blood में गया ना, so blood से सभी vessels में चला जाएगा. Okay. Now I'll talk about it. Now let's see. So do you understand this or not? Okay. The dye has been given intravenous. If the systemic blood returns into the right atrium, then right ventricle, goes into the pulmonary artery. From the lungs, it goes into the pulmonary veins, then into the left atrium, then left ventricle, then aorta. Okay. Now, beta intra-arterial, beta, some of you are asking this question. Beta, देखो आपके now think about it like your family member. आपको अपने family member का CT करवाना है. Do you want his artery to be punctured, or you happy with the peripheral venous injection, बच्चे? You understand this or not? Arterial injection will be more invasive. It will be more traumatic to the patient. If I can do it with IV dye, why not? Do you understand this or not? समझ पा रहे हैं बेटा? Do you understand? Intra-arterial देंगे बच्चे. Intra-arterial would be बेटा artery puncture करके देखो ना. It is a traumatic procedure. It's more invasive. That is why now, if you can understand, you have given an answer to your own question. Now you remember for brain aneurysm, IOC was CT angiogram, but the gold standard was DSA, which was invasive, which was done in the cath lab by arterial puncture. But CT angiogram is done with simple IV injection. Are you clear? Okay. Now, then some of you are saying, then sir, what is the difference between CCT and CT angiogram? The difference is in timing. CT angiogram, we take the CT images or very early after giving the dye to look at the blood vessels, to look at the arteries, while in CCT, we want to look at the tissue taking up the dye. Now, I am sure you can understand, if any tissue is inflamed, better please understand, or if you have a tumor anywhere, do you know if you have inflammation anywhere, you will be having hyperemia, increased blood flow. If you have a tumor also, you will have angiogenesis, new blood vessel formation. So CCT is looking at tissue. Things like inflamed tissue or tumor will be taking up the dye, which I will show you when I teach you brain tumors and inflammatory pathologies. CCT, we are trying to look at the tissue level of uptake of dye. CT angio, we are looking at the arterial phase. Okay, so the difference is in their timing. Very good. Gold standard is the accurate test, but it could be invasive and it may not be usually required. Okay, now everybody is clear. Now I want you to look at this patient. Okay, I want you to look at the patient and tell me, what body part are you looking at? Okay, what body part are you looking at? We are looking at the thorax. This is not the brain. Better don't get confused. These are your lungs. Okay, these are your lungs. Okay, these are your lungs. So if these are your lungs, okay, if these are your lungs, this is your ascending aorta, this is your vertebra, this is your descending aorta, this is your main pulmonary artery. Okay, this is your main pulmonary artery. Okay, should I repeat or are you able to gather? So, do you remember from your anatomy knowledge, I'm zooming the image so that everybody can see it on their phone. Ascending aorta is more anteriorly placed. Descending aorta is right next to the vertebra. It is posteriorly placed. Okay. Now I want you to look at the image and tell me, where is the disease located? Now, is the descending aorta having any disease, or there is no, we cannot say? Tell me, do you have any disease in the descending aorta, or we cannot say? We cannot say, because the dye has not yet reached the descending aorta, because after the IV injection, the dye reaches the aorta, pulmonary artery first, then it reaches the aorta. So this dye has not reached the descending aorta. Can you see there is a filling defect? There is a filling defect where the dye is not filling in at the pulmonary bifurcation, like a saddle shape. So this is a saddle shaped pulmonary embolus. And this is the same image that they asked out of my book in 2019 NEET PG exam. Okay, so this is the image that was there from your class notes. Okay, so this is how the pulmonary embolism would look like. Are you clear? Are you able to see this? MPA is the main pulmonary artery. Main pulmonary artery divides into the right branch and the left branch. MPA is the main pulmonary artery. AA is ascending aorta, DA is descending aorta, beta. Okay, ascending aorta, descending aorta. MPA was main pulmonary artery. Everybody clear? Okay. So my question is again, what is the investigation of choice for pulmonary embolism? When would you suspect pulmonary embolism? When you have a bedridden patient with sudden onset breathlessness in the cushion. Are you clear? If you have a bedridden patient with sudden onset breathlessness, okay, so the investigation of choice here will be CT angiography. Did you notice? This was a CT angiogram where we were trying to optimize the study, the timing to look at the pulmonary artery. Are you clear? Are you clear? A bedridden patient with breathlessness. We think of, I hope all of you know this, but when you are bedridden, you have stasis in your leg vein. Because of that stasis, you develop thrombus. If that thrombus breaks, it can go into your pulmonary vessels. That is called as pulmonary thromboembolism. So the key words will be a bedridden patient, breathlessness, and the answer will be CT angiogram. The image will be the one that I'm showing you in the class. Second number question. What is the screening investigation that we do for pulmonary embolism? The screening investigation for pulmonary embolism is the one that you read in pathology. You will do a D-dimer assay. And I'm sure you are aware of it, that if there is coagulation happening anywhere, the D-dimer, the fibrin degradation product will be increased, the D-dimer will be increased. Okay. And so this is called as screening test. This is not the diagnostic test. This is screening for pulmonary embolism. Is D-dimer assay. Investigation of choice is CT angiogram. Okay. Timing gradually I will come into more and more images. Timing मतलब बच्चे इंजेक्शन देने के बाद, डाई के इंजेक्शन के बाद कितनी देर बाद सीटी कर रहे हैं will determine that am I looking at the arteries or am I looking at the tissue. जल्दी सीटी करेंगे तो आर्टरी दिखेगी, डिले करेंगे तो टिश्यू में डाई आ जाएगी. Okay, that is the thought process. So screening for pulmonary embolism is D-dimer assay. Investigation of choice is CT angiogram. What is the usual chest X-ray finding? The chest examination as well as chest X-ray is found to be usually normal. Pulmonary embolism, chest X-ray is found to be usually normal. D-dimer assay is, बच्चे आप लोगों ने पढ़ा होगा, is a pathological test. कहीं पे भी coagulation होता है तो बॉडी में, ब्लड में D-dimer बढ़ जाता है. D-dimer is a fibrin degradation product. Are you clear? Okay. Everybody clear? Yes. So investigation of choice for pulmonary embolism is CT angiogram. Screening is done with D-dimer assay. Chest X-ray is usually normal. Okay, let me ask you a visual again. Okay. Let me, so that embolism was at bifurcation. Correct, bache, correct. No, beta, some students are getting confused. But जो brain में जब मैंने femoral artery बोली थी, वो DSA में बोली थी. I said femoral artery in digital subtraction angiogram, not in the CT angio. CT angio हमेशा IV dye से होगा. Okay, CT angio is done after IV angiogram. Everybody understands. Very good. Now my question is this. Now suppose I tell you this patient is a very important question for your exam. आएगा बेटा जरूर लिख लो. Suppose this is your ascending aorta, descending aorta, pulmonary artery. Okay, ascending aorta, descending aorta, pulmonary artery. Now imagine if this is your heart, left ventricle. Okay, try and imagine with me, beta. Don't be in a hurry. एक बार समझ लो. If this is your heart, this is from your heart, left ventricle, ascending aorta. this is your arch of aorta, and this is your descending aorta. Okay, everybody, these are okay. बच्चे देखो, everybody. Now please see, suppose there are two possibilities. Suppose somebody has hypertension or somebody has a collagen disorder like Marfan syndrome. What will happen? Now, in hypertension, the blood is hitting the aortic wall with a lot of force. Are you clear with this or not? In hypertension, the blood is hitting the wall of the aorta with a lot of force. In Marfan's, the vessel wall is bruisable, it is weak. What happens is, because of the blood hitting the vessel wall again and again, you develop a intimal tear. ब्लड ने चोट करके इंटिमा को टीयर कर दिया. Okay, through that intimal tear, the blood finds a way to enter the vessel wall. Through that intimal tear, the blood enters into the vessel wall. Now, let me give you the histology here. Vessel ka outer layer beta is adventitia, and the inner layer is intima. बीच में तो मीडिया ही होगा. Okay, so now in aortic dissection, what is happening? Intima is torn, intima tear हो गया. Blood gets a path to enter into the media. Now you have blood collecting between the adventitia and the intima. Okay, that is what is called as, I am sure most of you are able to pick up, aortic dissection. Every year you will have a question on aortic dissection, whatever may be the exam. Okay, whatever exam you may give, even if you go to America and give the exam, you will find the same things that I'm telling you they will ask, because they are important clinically. Now I want you to see the image again. I'm sure you will be able to pick it up, बच्चे. कोशिश करेंगे, बच्चे देखिए. Do you see in the ascending aorta in this patient, you can see two lumens. Can you see the larger outer one is the false lumen, then you see the intima, and actual lumen is this. Are you clear? Are you able to see this, bache? The false lumen is the one where the blood has forcibly gone, so what dye bhi wahan pe kam ja rahi hai. Can you see? The dye is also going less there. And that is why the false lumen is enhancing less than the true lumen. It is picking up less dye than the true lumen. It might have more sluggish flow. It might even get thrombosed. Are you clear? Should I repeat? Okay, should I repeat? Okay. So what I want you to do is, I want you to do a quick, pause here. Just I'm pausing it here. Okay, so just I had something urgent to sign. So I hope you can see now. This is the pathophysiology of Marfan's and hypertension, why they develop aortic dissection, and this is how it looks like. Are you clear with this or not? Okay, now my question is, beta, let's see an answer now. Aortic dissection is clinically classified by a system called as Stanford classification, beta. Okay, Stanford system will classify aortic dissection into type A, type B, type A, type B. So blood is between the intima on one side, adventitia on the other side. Blood media के fibers के बीच में इकट्ठा हो गया, जो media के fibers में चला गया बेटा. Are you clear? Okay. Now everybody understands. Now tree. Now if the aortic dissection is involving the ascending aorta or arch of aorta, even if the descending aorta is involved or not involved, we will call it Stanford type A. If ascending aorta or arch are normal and the dissection is only involving the descending aorta, we will call it Stanford type B. Are you clear? Will you write it down? Okay. Will you write it down? Okay. Everybody, please write it down. Okay. I want everybody to write it down. अगर aortic dissection ascending aorta और arch को involve कर रही है, we will call it Stanford type A. Descending aorta may be involved, may not be involved, we will still call it Stanford type A. But if only the descending aorta is involved and ascending and arch are normal, we will call it Stanford type B. Okay. Deep A classification is not clinically so relevant. It is more of a pathology concept. Radiologically, clinically, we mainly deal with Stanford classification. My question is, bache, this. Look at the image here and tell me what type of aortic dissection do you see in front of you? What type of aortic dissection is this? What type of aortic dissection? Stanford type A. This is Stanford type A dissection. Okay. Are you clear? Are you able to understand this? This is Stanford type A dissection. Everybody understands the concept? Yes? Okay. Yes. Because the ascending aorta is involved, we call it A. Now, why this is so important to know? I'll give you the idea, beta. Dekho. Now, let's see if you can answer. Listen to me, beta. Everybody listen to me. If there is a aortic dissection happening, what is happening? There is intimal tear and the blood is entering through the intimal tear into the media. My question is, what if the blood also tears the adventitia? Then what will happen? अगर blood ने adventitia को भी tear कर दिया, blood ने ताकत से, अब क्या होगा? If the adventitia also ruptures, the blood will collect in the pericardium. Because you know that the parietal pericardium is fused to the aortic root, the blood will go into the pericardium rapidly. So this rapid accumulation of the blood in the pericardium will not allow left ventricle to expand. जैसे ही pericardium में rapidly blood इकट्ठा होगा, pericardium expand ही नहीं हो पाएगा, heart expand ही नहीं हो पाएगा. What do you call it? You call it cardiac tamponade. So I am giving you a question to answer. Which type of aortic dissection can lead to sudden death because of cardiac tamponade? The answer is Stanford type A, because it has to be the ascending aorta to cause cardiac tamponade. And descending wala dur hai, wo cardiac tamponade nahi karega. Okay. The second question is, please see an answer. What blood vessel do you think arises from the aortic root and supplies the heart like this? Coronary artery. So the coronary arteries are arising from the aortic root. Remember, the sinus of Valsalva hote hain, wahan se arise kar rahi. So if the dissection involves the coronary origin, patient can develop massive acute MI. Okay. Okay. Patient can develop massive acute MI. Okay. So that is why anytime you have a patient with Stanford type A dissection, you need a urgent vascular surgical intervention. You need to take the patient to OT as fast as possible and repair the dissected part with a Dacron graft. If you don't do this, patient will die. Okay. So there is no role for any medical management in Stanford type A dissection. You need to take the patient as fast as possible to the OT. The answer always has to be urgent surgical management is required. While Stanford type B can be managed medically. Are you clear with this or not? The Stanford type A is the one where we need medical management, because Stanford type A is the one where we need urgent surgical management because of the cardiac complications. You may develop MI, you may develop acute MI. And if the aortic valve is involved, you can develop acute aortic insufficiency also. The valvular insufficiency can also develop. So the cardiac complications are more in Stanford type A dissection. So in your exams, what happens is, MI बेटा इसलिए ना बच्चे सोच तो ना बेटा सोचना, ये आर्टरी है बेटा देखो, Okay, let me explain it to you. Suppose this is your aorta, यहां से coronary निकल रही थी, अब आपको यहां dissection हो गया इधर, at the area of origin यहां dissection हो गया, यहां sluggish flow है, यहां thrombus बन गया, अब क्या होगा? MI, huh? So in the false lumen, you understand, if the coronary origin is happening from the false lumen, there will be thrombus and the MI would happen. Do you understand? Are you clear with this? Are you clear? If the aortic dissection, if the coronary origin is involved with the dissected area, तो वहां पे MI हो जाएगा. So that is the key here. That is the key here. Okay. So that is why you read all this in pathology, but you never understand this in pathology. Okay. Now question is this. Okay, everybody. What is the management of the patient shown to you on the CT scan? Answer is urgently take to the for surgical intervention. Urgent surgical intervention is required. Otherwise, the patient will go. And that is why you need those Stanford classifications. Are you clear? Okay, yes, very good. Now, okay, now let's see and identify the next image. Any one of you can tell me what technology have we used here? बच्चे आप ना कंफ्यूज हो रहे हैं. आई कैन सी सम ऑफ यू आर जस्ट मगिंग अप थिंग्स. बेटा वो आयोटिक एनोरिज्म के लिए आपने 5 सेंटीमीटर पढ़ा था, ये डाइसेक्शन बताया मैंने. एनोरिज्म अलग है कि एनोरिज्म होगा जो वेसल डायलेटेड है. ओके, यहां डाइसेक्टेड मतलब इंटिमा और एडवेंटिशिया के बीच में फॉल्स ल्यूमन बन गया. दैट इज डाइसेक्शन बेटा. ओके, आर यू क्लियर? ओके बच्चे, नाउ सी व्हाट डिड यू सी इन फ्रंट ऑफ यू. इज दिस अ सीटी स्कैन? इज दिस अ सीटी स्कैन? द आंसर इज यस. This is a CT scan showing 3D reconstruction. Today, if you remember, I told you in the beginning of the class itself, the CT has 3D capabilities. And you were thinking that sir is telling such a basic thing. But now we will use it clinically. CT has 3D capability, X-ray is 2D. So now tell me, what will you prefer for pelvic fractures? What investigation will you prefer for acetabular fractures? Anybody? Okay. Now you know in these complex fractures like pelvic fractures, you will read this in gradually in orthopedics. Pelvic fractures, pelvis is a very complex ring-like structure. So if you have one fracture, you will also have another fracture because of the ring-like anatomy of it. You have to do a CT with 3D reconstruction. So in the exam, they will say 3D CT. So today it is possible to do 3D reconstructions with a CT scan, and this is how it looks like. You can see how beautiful actually it looks like. You can keep looking at it for some time. It's so beautiful. You can see how the pelvis looks like this is how the bony pelvis looks like on a 3D CT reconstructed image. These are all computer generated images where we are able to do this. May I ask you now, what organ is shown to you? What organ is shown to you and what are we trying to see here? Now in the next image, I am trying to show you a cardiac CT. I am trying to show you a cardiac CT. Are you clear? Okay. Okay. This is a cardiac CT. Very good. Now, can we do a CT of the heart? Yes, we can do it. Yes, we can do it. Now, let me explain to you. Now, earlier, I'm sure some of you might have seen it happen. Some of you may not have seen it. But, bache, whenever you go to a hospital to see a CT being done, whenever we are doing a CT, the patient should not move. So, if I'm doing a head CT, I will tell the patient, don't move your head. Sar mat hilao. When I'm doing a chest CT, I will say, saans rok ke rakho. Okay? Because the patient should not move when I'm doing a CT. Now, can you guess and tell me what is the problem with cardiac CT? What is the problem with cardiac CT? Any one of you? Okay. So let's see now. So now everybody understands the cardiac CT is not possible because heart is constantly moving. So it is very difficult. You cannot tell the patient कि भाई heart रोक लो मैंने CT करना. He will not agree. Whatever you may say, he will not agree. But the key here is Suppose I have a CT machine. Listen to me, everybody. Listen to me. लिखने में एक ही word है, but listen to me. Suppose I have a CT machine which is able to do, it is able to rotate around the patient faster than my heartbeat. Now understand now, in 60 seconds, the heart is beating for 72 times. That means one heartbeat is 0.8 second. So if my CT machine is rotating around the patient faster than that, I can do a cardiac CT. And that is possible today with the advent of a CT technology called as multi-slice CT. This is called as MDCT, or we can call it multi-detector CT. I'm sure you might have heard of this in your college. When you came to the first day to the medical college, your college principal welcomed you by saying that today our hospital also has 64 slice CT. Welcome to the hospital, welcome to the medical college, like that. Okay, are you clear here or not? So you might have heard of 256 slice CT, 32 slice CT, like that. So what happens is, in olden times, when the CT machine was rotating around the patient, in one rotation, we were taking only one section. But now the machines have capability. For example, if I have a 64 slice CT, one rotation, CT can take 64 sections in one rotation itself. And that is what makes it very fast. So today, cardiac CT is also possible because of okay, because of 64 slice CT and multi-slice CT. And the technology is useful here. You might have heard of some test in your family member, somebody might have got a health checkup. Have you ever heard of something called as coronary calcium scoring? Okay, sometimes if some of your family member will go for a health checkup, sometimes we do a cardiac CT only to check the status of the coronary. We do a CT. If the coronary is calcified, we quantify it and we tell the patient what is the risk that he can have a coronary artery disease. This is called as a Gadsden scoring. Okay, should I repeat? Are you clear? Are you able to understand this? That in cardiac CT, listen to me, beta. Today, with the advent of multi-slice CT, we can do a cardiac CT. In that, we can even see the coronary calcification. If it is calcified, we tell the patient that you have a chance of developing coronary disease. So it is a kind of a screening procedure. So that is why in health checkup, sometimes we use coronary calcium scoring. They might ask you in the exam, coronary calcium scoring is done with, you have to answer as CT scan, multi-slice CT. And the name of the method is a Gadsden scoring. The name of the method is a Gadsden scoring. I'm repeating it. Are you clear? I'm repeating it, beta. Okay. So cardiac CT has a screening role for normal people, but if they come for a health checkup, we do a CT and we look for amount of calcium in the coronary. If it is significant, we think that there is atherosclerosis. We think that this patient needs further evaluation. This is called as screening. Okay. Okay, everybody follows. So this is how it looks like. The first image, this is a 3-dimensional cardiac CT image. This is a 2-dimensional image. And these are your coronary trunks. You can see the left main coronary artery here. Okay. Okay, this is a cardiac CT image. This is not the calcium scoring that I'm showing you. I'm just showing you a sample image just to give you an idea, the possibility with the CT scan. We can see the heart, we can see the coronary also today with the cardiac CT. Everybody follows? Okay. And this is all color shading has been done so that it looks like what the real thing is. Beta, ये सब हमने color shading इसलिए करते हैं computers, so that we see this organ just like you would see it in the body on a CT scan, so that we are able to understand it more easily. Okay, this is all 3D reconstruction methods that we are using here. Now I want to ask you one question. Do you think now the image that you are seeing, do you think this is a CT scan? This is a latest CT technology available today. It has never been asked in any exam, but it is given in your Harrison's and textbooks. Please see. This is called as dual energy CT. This is called as dual energy CT. Also, we can call it as dual source CT, or we can call it as spectral CT. Now, it has additional ability to characterize the crystals and stones. Okay, we'll not go into the physics, that is okay. But just understand, today there is a latest CT technology available called as dual source CT, spectral CT. This is synonymous, both of them are same, they can write anything in the question. It has the ability to characterize crystals and stones. So this is nowadays being used in urinary stones as well as in patients with gout. Okay, it is being used in urinary stones as well as in patients with gout. Okay, so okay, everybody understands? Okay, so this is a sample image where we have done a dual source CT in a patient with gout. I want you to see the image. So these green image structures that I have shown by my arrows are nothing but uric acid crystals. So I am sure in your so far in your classes, some of the teachers might have told you, okay, beta, when you see uric acid, the needles on microscopy are needle shaped, remember? And the calcium pyrophosphate are those envelope shaped crystals. Did you read all that? Yes. But today the technology has advanced so much that without taking out the joint aspirate, I can directly do a CT and tell you that this is gout, and I can map wherever uric acid is present. The CT is able to map all that. Okay, so this is how it looks like. Okay, spect is different beta. Spect I will tell you later on. Spect मैं बाद में बताऊंगा बेटा. Okay, okay. इको पे बच्चे आप अभी समझेंगे धीरे धीरे, मैं आपको और दिखाऊंगा, घबराना नहीं बेटा, बस लेट्स फर्स्ट ऑफ ऑल अंडरस्टैंड विद मी फर्स्ट, है ना? ओके, आर यू क्लियर विद दिस मच? Okay, and those purple things is the calcium phosphate in the bone. जो purple दिख रहा है बेटा, that is the calcium phosphate in the bone बेटा, and the green thing is the uric acid, and we are able to characterize that using a dual energy X-ray map that is available in the CT algorithm, and we are able to do this. Yes, it's not about expensive, it is just the ability and the machines, the lack of machines and all those stuff is there. Okay, yes, okay, everybody understands now. Now we have looked at a lot of things in CT scan. The only thing that I have to tell you here is, some of you were asking, sir, when you say contrast enhanced CT, what is the contrast material that you use in CT? Okay, so the contrast material that we use in CT is called as iodinated contrast. Everybody, can you write it down with me? The contrast material that we use in CT is iodinated contrast. Okay, okay, now see an answer. So iodinated contrast is based on an organic compound which has iodine. Iodine is a radio opaque substance. Okay, iodine is a radio opaque substance. Okay, so if I use a dye which has iodine and I inject it into the vessel, that vessels become white because of the presence of iodine in the iodinated dye. Are you clear? The iodinated dyes are used in CT scan because they have iodine, and iodine is radio opaque. Okay beta, now answer. These iodinated contrasts can be divided into two types. This will be slightly tough, but we need to know it. Ionic dyes, non-ionic dyes, and can be further divided into monomers, dimers, monomer, dimer. Okay, you need to write it down, beta. Okay. Yes. Okay. Now see, iodinated contrast are iodine-based dyes that are used in CT. They can be classified into ionic, non-ionic, and which can be further classified into monomers, dimers. Monomers, dimers. Okay. Now please see with me an answer. Okay. Iodinated dye. Listen to me an answer. Okay. Listen to me an answer. Ionic monomer, the classic example is urographene. Urographene is chemically called as ditriosate. Okay. Okay. And the orally taken form of ditriosate is called as gastrographin. यानी अगर यूरोग्राफिन में फ्लेवर डाल के if we make it orally acceptable we call it gastrographin. Okay, this extra things you need to write in the notebook. Workbook only for the images beta hai na. Okay, are you clear? Are you clear? Workbook is for the images mainly, and for your theory you should always write in the notebook. Okay, now please see an answer beta. Ionic monomer is urographene, which is chemically also called as ditriosate. The oral version is called as gastrographin. This dye has a osmolarity of 1400 to 1600 milliosmol. So nowadays we don't use it in CT any longer. Okay. Ionic monomers like gastrographin, urographine are not used in CT. We are not using them IV because of high osmolarity. Okay. We have high osmolarity and they will have more side effect. So now tell me, when you were doing your surgery class, and I know both foundation, regular, all of you have done surgery. In your surgery class, where did the teachers mention gastrographin study? Yes, ditriosate, urographine is same. Urographine is the trade name. Ditriosate is the chemical name. Bache. Okay, anybody? In surgery class, where did you hear about gastrographin study? So remember, in surgery, when they say for bowel perforation, the dye that they give orally, okay, dye that they give orally to see for the peritoneal leak is gastrographin. Now, are you able to remember? Gastrographin study is used in bowel perforation. Okay, not in the esophagus. Bowel perforation is the answer. Okay. And second place is, I don't know if you remember or not, there is an autosomal recessive disorder called as cystic fibrosis. Have you heard of this before? Have you heard of this before? An autosomal recessive disease called as cystic fibrosis. If an infant has cystic fibrosis or a fetus has cystic fibrosis, the meconium will be thick because in cystic fibrosis the mucus becomes thick. Now, because of that thick meconium, he may develop meconium ileus. He may develop bowel obstruction. So did they teach you either in pediatrics or in surgery that in meconium ileus we give a gastrographin enema? Can you tell me why? Because in these patients, it is both diagnostic and therapeutic. Can you guess the reason why it is therapeutic? Because it is high osmolar. This high osmolarity means when you give a gastrographin enema, it will pull the water towards it because of high osmolarity, and that helps to dislodge the meconium plug. So that is why you give a gastrographin enema in patients with meconium ileus, in infants with meconium ileus. But the key here is, if you don't understand, you will forget. But now that you have understood, I will guarantee you, you will never forget. Okay. But if you do not understand, you will keep writing, mugging up, writing, mugging up. 1 year goes, 2 year goes, time will fly, you will never get to know. Okay, the key is in the osmolarity here. Okay, so are you clear? Gastrographin, urographin, ditrioside is nothing but an ionic monomer with high osmolarity, only used orally for bowel perforation and for meconium For okay, everybody understands. There are not many ionic dimers available. The only ionic dimer available is ioxaglate. Only ionic dimer available is ioxaglate. It has a osmolarity of 600 to 800 milliosmol. Okay, everybody written it down. Only ionic dimer available is ioxaglate. It has high cost and it is not much preferred. It has a osmolarity of 600 to 800 milliosmol. Okay. When I come to non-ionic dyes, again we can have monomer, dimer. Non-ionic monomers are iohexol, ioversol, iopamidol. Non-ionic monomers are iohexol, ioversol, iopamidol. Yes. Okay. Now I see some questions here. Some students are asking, sir, gastrographin क्यों दे रहे हैं? Why not barium? बेटा देखो, barium is not soluble in water. So if you have perforation and you give barium, it will go to the peritoneum and it will get stuck there. वो निकल नहीं पाएगा क्योंकि water soluble नहीं है barium. And you know by now, if you have a foreign object in your body, body causes inflammation. Peritoneum will become inflamed, you will call it peritonitis. Okay, now are you clear? You cannot use barium in perforation because it will cause peritonitis. But gastrographin is water soluble and it can easily be used. Everybody understands? Okay, very good. So non-ionic monomers are iohexol, ioversol, iopamidol. They have a osmolarity of 600 to 800 milliosmol. Okay. Today, most of the CECTs that you see in your hospital, the most commonly used dye is iohexol. It is monomer, low osmolarity. That is what we are commonly using. And if you see in your hospital, some of you are intelligent enough to, see in the hospital. Some of you, when you go to the hospital, you don't look around. But hospital is the place to learn. Please look around. You will see our bottle named Omnipec. Omnipec. Okay, clear. Yes, very good. CECT, the commonly used dye is iohexol, which is Omnipec. Okay. And second is, please remember this concept with me. In esophageal perforation, iohexol is the preferred dye. I will give you my reason. In esophageal perforation, iohexol is the preferred dye. You might ask me, sir, अभी बावल में आपने बोला गैस्ट्रोग्राफिन, esophageal perforation में iohexol study क्यों होता है? The reason is that suppose you have a problem in your esophagus and I give you the dye. If there is a problem in the esophagus and I give you the dye will regurgitate. And the risk is you might aspirate the dye and it might go into the lungs. What will happen if gastrographin goes into the lungs, beta? Tell me. What will happen if gastrographin goes into the lungs? It will pull the water towards it and you will develop pulmonary edema. So that is why in esophagus, because it is thoracic location, there is risk of aspiration. We prefer iohexol study because if gastrographin is aspirated into the lungs, if it goes into the lungs, it will lead to pulmonary edema. That is why the difference in answer is Bowel perforation, please prefer gastrographin study. Esophageal perforation, please prefer iohexol study. Everybody understands? Yes, I think you have studied this in surgery and you are excited. Non-ionic dimers are iotrolan and iodixanol. They have an advantage of an osmolarity of 300 milliosmol, and I will call them as isoosmolar to plasma. They are, because of their osmolarity being same as plasma, they are very safe to use, and you can use them even in people with renal insufficiency. Okay, so I will tell you after this that these iodinated contrasts are potentially, they have a risk of causing renal injury, but non-ionic dimers, although they are expensive, but they are very safe because of being isoosmolar to plasma. So we use them even in, if I have to do a CT in a patient with renal insufficiency, the dye that we will use will be iotrolan or iodixanol. Okay, the advantage, isoosmolar to plasma, can be safe even if the patient has renal insufficiency. Okay, ioxaglate is IV used, but we usually do not. It has cost is more, and you can get the same osmolarity with the monomer iohexol, so it is not so commonly used. And some student has asked, can we use barium in esophagus? Yes, correct. Barium can also be used in suspected esophageal perforation. If the barium leaks into the mediastinum, it will cause only mild mediastinitis, which is considered clinically safe. Okay. So in esophageal perforation, somebody is asked, can we use barium? Yes, you can. But the preferred dye is not barium. Preferred dye is iohexol. Barium can be used in esophageal perforation because it causes only mild mediastinitis, which is clinically irrelevant. So we can use barium. But if I have to mark in my exam, the answer should be iohexol study. Yes. And the commonly used dye that we use in CT are non-ionic dyes. Commonly we use monomers. Dimers we only use if the patient is having some risk like renal insufficiency. Now we need to know as a doctor, whenever we are doing a contrast enhanced CT and we are giving the patient iodinated dye, iodinated contrast, the risk is some people can develop a non-IgE mediated histamine release, which is called as anaphylactoid reaction. ओके बेटा जी, देखो कुछ लोगों में वी कैनॉट प्रिडिक्ट. ओके बच्चे, कुछ लोगों में वी कैनॉट प्रिडिक्ट व्हेन वी गिव आयोडीनेटेड कॉन्ट्रास्ट, दे डेवलप non-IgE mediated histamine release from the mast cells, and that leads to anaphylactoid reaction. Mimansa beta. So we were preferring for CT, we prefer non-ionic dyes. Okay. Usually preferred iohexol, also called as omnipic. Okay, this is the preferred thing. Okay, bache. Now clear. Everybody understands? Now see. So please see. That is why you will see when you go in the hospital, the good nurses in the hospital, whenever a CT is being done, they first load adrenaline. And then they inject the dye, because just in case somebody develops an anaphylactoid reaction, you should be able to save life by adrenaline. But are you clear why we are calling it as anaphylactoid, not anaphylaxis? Because it is not mediated by IgE. Okay, second question. Second thing that can happen is Iodinated contrast can lead to tubulointerstitial injury in the kidney. Okay. To prevent that from happening, patient should be well hydrated before you do a CT scan. And we will say that the patient has developed nephropathy due to dye if you see rise in serum creatinine more than 25% above the baseline or zero point 0.5 milligram above the baseline, okay, after 2 to 3 days. That means, let's understand, if you get a CT done today, beta ji, and you find that the उस patient का creatinine 25% से ज़्यादा rise हो जाए या 0.5 milligram से ज़्यादा rise हो after 2 to 3 days, you will call it contrast mediated nephropathy. And to prevent this from happening, you should ensure as an intern, as a final year, that anybody who's undergoing a CT scan should be well hydrated. Should be well hydrated. That is all you need to know as an undergrad. इतना ही आपको जानना है बच्चे. Everybody understands? Okay, so this is what you need to know about the iodinated contrast and the CT scan. So let's kind of recap what we have done so far. What I told you today was I taught you what is the basic of CT scan. Then I showed you the CT brain anatomy. I taught you how to look at brain hemorrhage and brain infarct, including the arterial infarct, venous infarct. I taught you about CT angiography and common condition that you need to know, like aortic dissection, pulmonary embolism. Then I also showed you, I taught you 3D CT, cardiac CT, dual source CT, and the role of dual source CT in gout today. And I also taught you about the contrast material that we use in CT. This is what we talked about this. And we can use monomers also in renal insufficiency, but if you have money, you would always want to go for the safest thing, and the dimer being isoosmolar to plasma are the safest to be used for renal insufficiency beta. Are you clear? Okay, so this is what we've done so far in the class. Now, before we go home, I just want to ask you here that if before you go home and you relax, I just wanted to know, are you, what I normally do is when I finish CT scan, I talk a little bit about MRI to show you the difference between CT and MRI today. Or do you want to, call it a day and do it later? It is, let's have the discussion. Okay. Okay. But okay. So we can, my choices that I can give you are like this. Choice number A, continue. Choice number B, break and continue. Choice number C, bye-bye. Okay, what do you think? Because what happens is when I show you later on, then you might forget CT. So if I show you one or two MRI images, you will be able to do it better. But I don't know what you say. Do you want to continue, break and continue, or bye-bye? What do you think? I can see the chat box is going mad. And then people will say the app is hanging, but can you see no other app can handle the number of the messages that are running right now? It is running like a lottery ticket right now. Stop. Okay, so stop before the technology there's a limit to the chatting that is going on. Thousands of comments are happening. So okay, I can see most of you are saying bye-bye. So before we go bye-bye, so what did we learn today other than radiology? We learned, okay, fine, okay, we are closing the class here. In this class today, in addition to radiology, I have taught you how to integrate what you know with images. That is what we have learned. Second thing we have learned is understanding is more important than memorizing. Quality of your learning, okay beta stop, is more important than quantity. So the quality is more important than quantity. That is why I said, let's spend time, let's find out what is going on, let's understand more. And that is the entire theme that I want you to follow, and you will appreciate that this is what we always do. And the third thing I want you to know is, let's not, okay, this is my final message for the day, beta. We'll talk about more things in the next class. Have you ever seen in your academic section in your college, have you seen clerks? Okay, have you seen clerks in the academic section? Beta, do you think, okay, stop beta, stop typing, bache, okay, nahi to beta, finger mein injury ho jayega, okay? Now tell me, stop typing, okay, tell me, have you seen clerks in your academic section in your college? Do you think, do you think anybody dreams of becoming a clerk in a college? क्या ये किसी का सपना था कि वो क्लर्क बनेगा? नहीं बच्चे. Everybody dreams of being a civil servant, collector. Clerk थोड़ी सपना देखा था उसने, but he becomes a clerk. Now what happens is, because of that regret that you have in life, what happens is these people become clock gazers. Clock gazers होता है when you accumulate regret in life, when you don't enjoy your journey, you become a clock gazer. Clock gazer क्या होता है? ये लोग सिर्फ टेबल पे बैठ के घड़ी देखते रहते हैं, and their only question is, 4 कब बजेंगे? और मुझे मेरे बच्चों से ये चाहिए कि please don't keep, that I do not think like when somebody is always on, sir, time हो गया. But we are not those clerks, we are not those people who are regretting this. We are doctors and we are living a dream. आप तो सपने में आ गए हो. Okay, so you're doing something which is a massive respectful job. So what happens is, difference between doctors and this is that we don't look at the time. These people keep looking at the time. ये बोलते 4 कब बजेंगे. Okay, and when you go to them for any request for any certificate you need, they will say come on next Thursday. Try करना, हमेशा अगले Thursday बुलाएंगे, कुछ नहीं करेंगे. Okay, you don't want to become those kind of people. And what do you want to become? You don't want to regret. Okay, so the key in life is not such है कि ये नहीं है कि मैं क्या अचीव करूं या क्या ना करूं. The key should be, you should have no regrets. है ना, मैंने जो किया मैं अपना बेस्ट एबिलिटी से करना चाहिए. I should have no regrets, and I don't want to become a clock gazer जो 4 कब बजेंगे देखिए. Okay, so that is the idea that I wanted to leave you with. And so let's we will conclude the class today. In the next class, when you come, we will start with MRI in the next class. So now what will happen is, in the coming month, I will do a new thing here. In the coming month, I will keep shorter schedules of radiology, and mainly your classes will be happening of medicine, surgery, and obs and gynae. But there will be shorter classes, sometimes happening in the evening, sometimes in the morning. Shorter radiology classes आएंगी, where we'll keep clinically correlating. And I'm sure, once you learned all this, you must have been able to correlate some things that you might have read in medicine, या अभी आप पढ़ोगे थोड़े दिनों में medicine में CNS का class में शुरू करूंगा. So you will be happy that you know how to look at a CT of the brain and all those stuff. So I'll keep correlating for you. Thank you very much. It was a pleasure, teaching you all of you young minds. And I think, you're all brilliant students. And